Our next presenter is Philip Gable. Philip's a sports physiotherapist with a small practice in Coolum on Queensland's Sunshine Coast here. He's a PhD candidate at the University of the Sunshine Coast, and he's been investigating the link between screening and outcome measures and the prediction of recovery for compensation and sporting patients, including surfers. This afternoon he's discussing predicting outcomes in individual and team athletes through technology-based biopsychosocial screening and repeated outcome measures. So thank you, Philip.
Welcome to the full audience capacity. How are you going? So what we're looking at this afternoon in this particular presentation is an overview in a technological media system of most of my research work, trying to simplify into usable format. So what we try to do and aim for as physiotherapists in the sporting situation is to predict recovery. It's one of the big things we get asked to do, whether we're aware of it or not. And currently the majority of that degree of recovery prediction is based upon subjective opinion. It is your opinion and how you feel, and what you're coming up with for that opinion is based upon clinical tests, it's based upon region that's affected, it's the clinical guidelines that you've seen or read that give an indication as to how long it will take, along with things such as the injury mechanism, the tissue itself, and also your own individual experience, which means your prediction capacity changes as your experience as a therapist changes over time. However, opinions can vary considerably, not only between professions where, say, for example, a sports physician may come with a different opinion on prediction time to yourself as a therapist, but also between professions and even within the one individual, as said previously. So this, as a result, is that there is no integrated system of approach for determining what a screening prediction will give you and what the actual outcome itself is going to be. There's no statistical link that's been shown in the literature to date, and there probably won't be for quite a while to come. A new approach is one that is quantitative. So we're looking at an overview of a simplified system as patients and most systems look at something in a manner that is simple as possible, the old KISS principle. And what we're looking to do is to integrate biopsychosocial screening through the use of a simple 12-point shortened questionnaire and the use of outcomes on an integrated scale. And technology enables us to do this because behind the scenes of when you complete a questionnaire computer-based is the back room that can do these algorithms and perform these calculations on the fly and immediately produce a charting and system that's immediately available and exportable. So what's screening? Screening effectively is the early identification of risk, and it's something we do in all our patients at all times. Sometimes if we take the big step back and go back to where we were previously, we can go right back to the old nursery time stage of life. We can think of Mother Duck and what she does in life and how she identifies her risks and what the outcomes might be. And so what we can think of is outcome is really nothing more than the end point of what you're doing. And sometimes that's a positive outcome, and other times it's really a little less favourable. Lighten up. So let's go on to someone has, good to see. So let's have a look at the real world. So this is a junior professional surfer who's about to go to the World Championships. And what we did was integrated this system within their rehab, or his rehab, to try and help him provide a system of feedback and motivation to get the result he wanted. He had an ankle ligament strain. He lives just down the road from us. He has lateral anterior slips affected on his rear foot. Anyone involved in surfing understands that the rear foot is the critical foot for loading, particularly those that are involved in high-performance elites and aerials. So the aerial then he performed, completed a bottom turn, came off, lost it, and had an inversion sprain. It was 4 weeks prior to the Worlds, and he got back to where we live about 10 days after the injury itself and was non-progressing. So this system that he used and that we used with him enabled a progression because of its motivational component and gave him the confidence that yes, he was actually going to get there, because the day he turned up, he had pretty much resigned that he wouldn't be on the team any longer. So what we have is a very simple chart. Why do we use a simple two-dimensional chart? Because it's the easiest thing that's integrated for all components, for patients, for therapists, for payers, for coaches. We have an x-axis of time and a vertical axis that simply represents their position as they were and what they will be. So what we can see here is 100% represents back to normal for them, and down here is the worst possible. The little green line at the top here represents the time when most elite sports persons will effectively be back at work, and 80%, at sport, and 80% represents a cutoff that works out statistically on the calculations for prediction. So the outcome itself is a series of numbers that are put through an algorithm, and I'll go through it very quickly in a moment, but it basically produces a single number. That number is integrated for any part of the body, so it's the same scale for a back, a neck, or a lower limb. And then that number there is used to help us produce or to get a comparison of the feedback for what the screening is. So we can predict in a quantifiable manner a number based on days as to how long it will be from the time they complete a simple questionnaire, demographics and other information as to when they will reach a specific level. This is only a calculation that is never going to be finite, it's never going to be infallible, but it does give a guideline on best practice. So as that individual continues, we can see that the actual status improves, and then to a third point, after which we can use regression analysis, line of best fit, and what's called trend line feed forwarding to see that their prediction is going to be even close to what we suggested might have happened from day one. And then finally, full recovery. And in his case, the competition was at this point on the chart, and he could see, even from the second time that he came in, that he was going to make it. And that was one of his biggest motivators. So this system works off a simple internet base. You type www.adviserehab, and that takes you to the home page. It's a decision support software. It's a system you then log on to, provide yourself with a simple username and password, and we created one for this particular conference. It's just simply APA 2011. If you want to play with it, you're more than welcome. It's public available for about the next 6 weeks. Once you've gone through the username login, you get to a home page. The home page you then add for the new patient. You put in the date of where you are now, or you can backdate, forward date to a limit, but usually a backdate regression can be used as well. Bit of data, what kind of problem it is, click on next and move forward, add the name, what the condition is, who they are, what their date of birth is, and then go into the area that you choose. The algorithms work differently for the parts of the body, the age of the patient, the condition affected, and what the demographic situation is. So someone who's a whiplash will be mildly different to someone who's sporting. In this case, it's sporting. They choose the body area. We said in this case it was an ankle. And then we move on to what's called the prediction questionnaire itself. This is a modified, shortened version of the Arebro tool to 12 points. We've been waiting 6.5 years at the moment to get this published. It's been already researched and completed, but Domino Publishing limits you that you can't publish until the one before has been done. And we're still in the process of waiting for the article before this, before we can publish this one. And so they get into their duration of time that they've had the condition, and then there's a series of other questionnaires that are replicated down the sideline to tell them how far into that particular section it is. This takes probably 2 minutes to complete. The longest thing that takes to complete is actually getting in their name and address. So they complete these various screening prediction questionnaires. Then they'll move into what's identified as a combined section, things such as their overall status, the duties they're performing in life or how they represent that specifically to their sport environment, how much pain they're in and how they're performing. They then go on to a generic section for the entire body, a simple yes-no 3-point chart, which is the simplest system you can use based on cognitive function, as the human brain has the simplest ability to recognise those 3 categories. From there, we move into patient specifics, where this is not an example of a surfer, but someone who is another athlete, and they'll choose the kind of sports or activities that they have. In the case of our surfer, he was doing things such as bottom turn, cut back off lip, weight transfer to his back leg. They can specify it down to as fine an item as they wish to, and then have it on a 10-point scale. Then they move on to in this case, leg specific. And that produces a simple chart, and then that is then exported. The aim of all prediction or screening depends on your own perspective. So for a club, they might want to identify particularly time to return to sport, time of availability for the athlete, what are the potential costs, how much the resources are required and in which area, and then the level of management. Do we just give it to the guy who comes along once a week to help out as a masseur, or can this patient go on to someone who's a specialised sports physio? In terms of the treaters and the athletes, well, the first 2 things are a no-brainer. We want to know the same thing as well. How long till they get back and when will they be available? But we also want to know how much treatment's required, what interventions may be needed, and these kind of determinations of potential risk and recovery can give us an indication whether we might need to be calling in psychologists, people for social support, do we need OT, sports physicians, extra interventions, extra studies. Take a look at the big picture. Let's move on to 2 identical twins, Fred and Ted. So their profile is they've both injured themselves during the local chariot race. It was held at Stadium San Corpus. It was held at the same time, the same event, and they're both in the same team, which is Barnes Bronchosis. And so these 2 chariot riders are identical in every way possible. It's nice to see someone's got a sense of humour out there. So this question then comes down, okay, ID genes going to be ID recovery or not? Well, if not, why not? And how can we predict this? So let's take a look. Will it be the physical injury itself that was the problem, or will it be there in background? Maybe it's a combination of both. And I'd advocate it's actually a combination of both, not one specifically. Let's take a look at Fred. Now, he's been on the team now for several years. He's a stalwart on the chariot races. He's mature in his outlook on life, good health, married, good portfolio, and socially accepted by all his mates. Fred's only come in, he's a little bit borderline on the team now. You know, he's the twin brother, but he's still playing second fiddle. A little bit younger in his outlook in life. He's been really injured on this one. Recently broke up with his girlfriend, and the other week there was a bit of an incident, and yeah, anyway, so he's just out for a short time at the moment. Do you think they're going to recover identically? That's just looking at their psychosocial profile without going into your examination and the mechanics of what happened during that chariot race. The screening is a psychosocial and a physical way of helping us predict how they're going to go. The measurements in turn will then assess where they physically are in that situation. So if we look at this particular case, we've got on the left here our stalwart, and on the other side the newcomer. We can see that at the start they're both fairly close to each other in terms of where they began. But when we look at the screening prediction, the old stalwart's a little bit less, and the newcomer's showing up as having other problems in life that are going to delay his recovery. And so as time goes on, the low one, lower risks, recovers quite quickly, and the other takes longer time, but eventually reaches the actual incidence and prediction that we've given with this little orange box. Wouldn't it be nice if it happened like this every single time? So when we use screening and outcome measures, we're trying to use a prediction methodology that is accurate and self-rectifying. It has not only a feed forward, but a feedback loop that you can use and see where they are, where they've come from, and where they're going. So we can see here the prediction at the start is up to this point, and we can see the line of trend in what direction they're heading. It's also a means of providing real time. It's all web internet based, and it works off mobile interactive media. So you simply give the patient an iPad or some other tablet, and they complete it sitting there in the waiting room, and it's all self. It takes about 3 minutes to get the minor data in, 5 if they're not particularly effective, and then it can take up to 2 minutes to get the other data in. On repeats, we've got most patients down to under a minute to complete. Feedback loop then compares actual versus prediction, so we can see how they're actually going, which is this blue line and the green line versus what was predicted. In this case, it's pretty close. So this decision support software program gives us statistically based upon the analysed data from previous cases to give us the trend lines and algorithms. It's a mathematical modelling process using correlation coefficients and simple regression analysis, so that when they reach their final target and their final output, we've got some degree of feedback between the original, where they are now, and what the green line was predicting as the future. So we have a quantifiable model that compares immediate, past and previous with the future, has a prediction future recovery for competition for individuals and team members. It's graphic, providing the common language of visual history that's required by individuals, and it's easy to use. Instant communication can be exported and passed by intermediate mobile to anyone who requires it. It's accessible then to the athlete, the medical team, to the individual, as well as the coaching and management staff. So in summary, and what's the take home from something like this? I'm not saying this is the godsend and this is going to be the answer for everything, but this type of interactive and this type of decision support software is where things are headed in the future. If we don't embrace it, it will be dictated to us. So it's perhaps something we need to start becoming familiar with and adopting. In this case, it's unique as a forecasting method because it looks at recovery timeframes, return to sport or return to work and work activity in the timeframe that's realistic and individually specified. Its a technology role is going to increase over time, and just since this project started, to the availability of tablet PCs in a workspace and in a treatment room have made a significant difference in its application. It's interactive software that facilitates the process, quantifies the status and direction, and derives a decision pathway in a real-time setting. And it's useful for both rehab and sporting performance. Thank you.